Right. So welcome everyone to our afternoon session for today on developmental disabilities in California and disability policy and service access. I am very happy to welcome Lisa Krasner as well as Larry Landauer to give our talk today. Larry served with persons with disabilities over the past 33 years. He's the current executive director of the Regional Center of Orange County, the RCOC. He's received both a master's and bachelor's degree in social work, and he began his career at RCOC in 1988 as a service coordinator. Over the next 3 decades, he's worked his way up through the ranks, getting experience and firsthand knowledge in virtually all aspects of regional center operations, from service coordination, area management, and quality assurance, to the full range of community resources and public benefits for people with developmental disabilities and their families. RCOC is a private nonprofit organization contracted by the state of California to coordinate services and support for approximately 22,300 Orange County residents with developmental disabilities and their families. Developmental disabilities include intellectual autism, epilepsy, and cerebral palsy. And I can speak from some personal experience that I've been looking forward to this talk, as my dad was a rehabilitation counselor for his career for 35 years in an adult school program in Orange County.
Wow. Thank you, Reese. And with me is you're going to be very delighted. I have Lisa Krasner, who's a veteran of UCI administrator, whose professional background and interests include administration, education, public service, and local and global communities. Her personal interests include travel, cooking, writing, and the arts. She loves jazz, film, theater, and dance, especially the tango, which she dances socially whenever her time allows. Krasner's public service mission is in the workforce development of persons with developmental disabilities. Krasner serves in a number of community advisory boards, including the Regional Center of Orange County, one of my board members, Irvine Residents with Disabilities Board, the Irvine Barclay Theater, and the Center Club of Orange County. She presently serves as one of the family partners of UCI Center of Autism and Neurodevelopmental Center as part of the Autism Care Network. Krasner lives in Irvine with her husband and older son with autism, while her younger son attends college in Washington, D.C. Thank you, Lisa, for assisting me today.
Yeah, welcome to you both.
So let's, what you're gonna hear today is, let me just show some of the learning objectives, reviewing the services available to people with disabilities in California, outlining some of the successes and challenges of the Lanterman Act, identifying major legislation that paves the way for social services and healthcare access for patients with disabilities in the United States, define the role of the regional centers for people with disabilities, and observing current goals for disabled community in terms of health policy change. So we will be answering all those questions throughout the topics today. And I think one of the best ways to get into that is through vignettes. I've found that's one of the best avenues to really hopefully have the different scenarios kind of help with it sticking with, you're going to remember these things. The regional center system and services in California to the developmental disability population is the best in the country. California has led the way for over 50 years as a state that was committed to serving people with developmental disabilities no matter what. So if you're in California and you have a developmental disability, you were to get services. And I'm going to really show you all that history really in a fast kind of snapshot towards the end. But what does the regional center mean? What is it to families who have a child with a developmental disability? That's what we're going to explore right now. So let's just take one one avenue. A pediatrician alerts a parent to some possible delays with their child. They'll refer that person, that child, to the regional center. That's probably the primary way that we get referrals. We also have nurses and psychologists and doctors, a couple of doctors, and we're working with our neonatal units all over Orange County as well. As one of the mandates of the Lanauer Act is what we call child find. We want to make sure if there's a child out there that can benefit from the services, we need to get that. And I'll talk more about some of the astonishing statistics at how important it is to get services to children at a very early age. So this would be one avenue that, and when we get that child, you're going to see occupational therapy, physical therapy, and speech therapy is the typical things. Another is, and I'm going to kind of go through the life spectrum, because the other thing about the Lanauer Act is really it's an act that serves from birth through the whole lifespan, all the way through death. Developmental disabilities are conditions that are lifelong, basically. So here's another scenario. A child going to school is exhibiting increased behaviors, starts having increased tantrums, hitting, other types of behaviors. Right now, the primary therapy for this type of thing is what we call applied behavior analysis. So the school is going to be dealing with behaviors that occur in the school. When you have a developmental disability, it's not like you would see in the general population. You could get suspended, you could get sent home, you could get called to the principal's office. But if somebody has autism, somebody has intellectual disability, we're going to be trying to solve how do we get to the bottom of these increased behaviors. There's a number of things that have to occur, and I'm not going to steal some of the thunder that you're probably going to hear from Lisa. So in this regard, we would make sure to work with the school on how can we, usually it's going to be applied behavior analysis to help the child. And then we're going to be coming in, and if that carries forth when the child comes home from school, if the sibling is fighting with their siblings, fighting with the parents, and these types of things are going on, then we would have a therapist, behaviorist in the home working on the same things. And once again, you really want to parallel the school. You want the child to have a consistent treatment throughout. So you want it to match the school as well. So those are things that we would be working with the family and the school and trying to hopefully get the child back into a more stabilized state. So that's a big area that the regional center is very helpful to families when these things occur. And this is not an unusual process with somebody with autism or intellectual disabilities. Another area that helps with understanding this kind of spectrum of services is every child that has a developmental disability and has individual educational plans through the school system, at age 14, they're going to start what's called transition planning from education. And for the most part, our population goes through school to age 22. And they complete at age 22 with a certificate of completion. Now, with the increased incidence of autism over the last 30 years, there has been more people graduating from high school. So that can occur at age 18, but we see far more needing to go to age 22. So what's different about normally an individual at age 14 starts high school? With our population, they're going to stop the kind of educational types of things and start preparing for the future. The greatest thing that we can do with our population that's not really going to go to college, good chance they're not going to go to typical college to get degrees. We're going to start working on what's going to be important for employment, what's going to be important for them to be able to get a job, hold a job. Employment is one of the greatest foundational things for everybody. If you have ever been out of work, even if it was for a few weeks, you know that sense of terrible feeling that comes over you. Work is important. It's important to every single person, and it's no different to a person with developmental disabilities. It's just it's trickier trying to find the right position, the right job. And our people can be the greatest employees when we find that correct job. But at this point, Lisa, did you want to share from a personal standpoint, as a mother and has gone through this process, the transition kind of experience from a mother's perspective?
Yes, my son is 26 years old right now, and he is actually what we would call has transitioned or is transitioning. But I want to go back a little bit and refer a little bit more to some of these key points in here in terms of this vignettes, because I've gone through just about all these levels of the story, but the version that sometimes happens can vary from what is really clear already in here. So for example, this bullet number 1, where you have the pediatrician alert to possible delays in your child. For many families, certainly about 26 years ago, many pediatricians are hesitant to diagnose a child with autism. It's usually given to that falls under the purview of a neurologist. So if there's any of you in here who might be pediatricians one day, I don't know who my audience is. I'm going to assume some of you are Prime LC or pre-med or are in the School of Medicine already. One of the things that parents experience sometimes is, why is this pediatrician noticing something and they're referring me someplace, but they're not telling me everything? And what we have discovered along the way is that pediatricians generally, from experience, do not like to diagnose a child with autism. They leave that to the neurologist. So in this other way, but they refer them, and that's how the regional center gets the services, and they can help in this process of diagnosis appropriately and then bring them into the system. The child going through a school that displays certain behaviors, if you have a child who might be nonverbal, you know, there is an issue in there, they could be hitting. A child usually is referred to go to a pediatrician or a doctor in this regard. And one of the things that could be happening in here is that a child who is nonverbal may not be able to express what they're really feeling. And going to the doctor is a good thing, but in this case, my real story in here is my child was hitting in the school, and he was put in a straitjacket for 2 days in a row. I found this out later just to find out he had a toothache. Okay, so what we're trying to understand in here is, I don't know if this is a policy thing in the school or just misinformed people or people who are not familiar with what is going on in the child. I found out I didn't really need a doctor. What I needed was a dentist. You see what I'm saying? This is what happens in the real world. A child who turns 14, this is really important for when it comes down to regional center services, because these years from 14 to 18 goes by very, very fast for a parent. When my child turned 14, I started wondering what's going to happen to my kid when that yellow school bus stopping at my house to pick up my child for school. And that is our version of the kid turning 18. Everything else stops. You know, you get kicked out of the house. In this case, you get kicked out of the system, and you now become the responsibility of somebody else. The school system is what I mean. So parents go through a really lived-in version of a lot of these things in here, but the reality of it all is, if it wasn't for the regional center, there probably would even be less help today. Okay, so we live in an entitlement state for these types of services. So I think if there's anything that we need to take away in here, we need to understand what that means. And we also need to understand perhaps what the role is for a physician when it comes to trying to really understand what we are able to do with a child with a developmental disability and what the policy does say in terms of the allowability of giving either a diagnosis or directing the help so that parents don't have to wait so long before they can get a child properly diagnosed or into the services that the regional center provides, which is in this case, the whole lifespan. So that's where I go right now, Larry. You can turn it back over to you unless there are questions.
Thank you, Lisa. The next scenario we'll use is a 26-year-old person that we serve requests to move out of the parent home. That's not too uncommon. They see their brothers and their sisters going off to college, going off to work and moving out of the family home. A lot of times our population, people we serve, will want to follow similar types of paths. So at that point, what we manage and maintain and work with is licensing. So there is group homes at all different levels for like no behaviors up to significant behaviors. And then probably the most preferred for the last 15, 20 years is living in one's own apartment or sharing an apartment. And in those situations, somebody has to have a housing voucher, housing certificate to be able to afford the rent. And what the regional center does is provide the staffing and the services to help that person. So a key, the Lanterman Act provides for services needed related to the disability. We have to utilize every single generic resource, what they call it. So it could be Medi-Cal, Social Security, all these things, IHSS, in-home support services, all these things have to be utilized, and then the regional center funds start coming in. In order to live in one's own apartment, they do have to go through housing. And that is, these days, is at least about an 8-year wait. So when housing lists open up, we encourage families. A lot of times, if they're 18, the family's like, he's not moving out. No way, she's not moving out. And we go through, let's just apply, let's just get, because these windows don't stay open very long. But in 10 years, if she's ready for moving out, that HUD certificate opens up all kinds of options. It's no longer just a group home, but we can easily look at apartments, because the HUD certificate basically allows our population, who might only make $900 in Social Security, to be able to actually live in a $2,000 apartment. How is that possible? Well, HUD is based on, it's a third of what you make. So if you're making $900, your rent is going to be $300, and then you'll have $600 to live. Not a lot, and it is basically poverty, but then the HUD certificate pays the additional $1,700 to the $2,000. So that's how our folks can live, and how HUD vouchers work. So you can see it's gold to a person in order to be able to live independently or live in their own apartment. If that's not an option, then we do have to look at group homes. Group homes are shared. Most of the time, you try to get a private room for 4-bedroom, 5-bedroom homes. Sometimes there are 6-bedroom, and that's the maximum. So those are so helping people with living outside of the parent home. So I mentioned in this case, it's the individual request. It's also at times where the parents are requesting, saying, we can't do this anymore. So that might be at age 45, that might be at age 55, and then we're doing the transition at that time. So I think as you're seeing this whole lifespan of the Lanterman Act, how valuable it is to families with developmental disabilities. And it's going on, it's almost like its 54th year, and we'll get into the history a little more. But this one with the 26-year-old gives a very good example of all the services and help that we can provide. And last area is, and these are just simple vignettes. There's thousands and thousands. Today there was hundreds, probably, with the 22,300 people that we're serving, the 307 social workers, service coordinators. all with caseloads close to 85 to 90. They're getting calls all day today doing different things. So this is just going on at an incredible clip, basically. But this one is an interesting one too. Adult gets into trouble with law enforcement. Well, a lot of times when you have a developmental disability, if you have autism, you have intellectual disability, IQ, especially IQ of 52 or so, or anywhere in there, your impulse control is not going to be as good as other people's impulse control. So there's 7-Elevens all over the place, AM, PMs, and our folks love Coke as much as anybody. And here are these big fountains and these big, huge, massive 64-ounce types of things. And if they get the opportunity and they don't really understand that that's not a free-for-all. It looks like it, huh? When you go in there, it's just right there. There's cups, there's straws, and there's a fountain. You just want to get it and then you just go. So if they don't have supervision, they could get in trouble for those types of things. So that's a good one, because in that situation, the law, the system is built to look at that, that this person has a disability. It wasn't a typical type of crime, and they're going to pull us in, or the regional center. We work closely with the courts as well, and we're going to work on what we call a diversion plan. So the courts are going to say, how can we help him not get in trouble with the law in the future? So it's going to be an increased supervision is going to be put in place on this type of individual. So very important that we find the caretakers or the personal assistance type people to be able to assist the family with making sure he has to be shadowed, or he has to have an eye kept on him so he doesn't get into trouble. So that's one other example of a service. And again, it's the whole life spectrum. Everything you can think of that happens in life happens to people with developmental disabilities. And these are just a few samples to give as we go through. So you can see how vital this is to the people we're serving, to have a resource like this for their families and for themselves. When I go through the history, you're going to see, how does a program like this get funding? Well, you heard we're a private nonprofit, and you're going to see why that was actually quite genius way back over 50 years ago, at how the state did that, and the savings to the state in many ways than having this put as a county operation or state operation. So in order for us to maintain that, we do legislative visits. We meet on a regular basis with our senators and our assembly members, reminding them of how important this system is. There's 361,000 people with developmental disabilities across the state of California, 22,300 here in Orange County. And why is this program so important? So we have to keep on their radar, because the Lanterman Act is a law and it was put into place, but it also states that the legislature needs to fund it every year. So it has to be funded. So when we make these legislative visits, we're reminding them. I usually have a parent like Lisa. I have a person that we serve. I have a vendor that we have that's a business that helps families. And we talk to the legislative person, and we're always trying to make sure they get it. And an example last week in a visit that I was in, the district director actually, they got the legislative staff and the senator, they're very busy. But in this, I knew we had a great connection, because this individual, the district director said, oh, my good friend has a son that has autism, and he's been working at the grocery store for 9 years. And he just is the greatest employee. I said, yeah, and he's a taxpayer. You really sell those points, and you see how valuable the system is. So those are things that you hope that you connect with families, with the senators and assembly members as you're going through, because when funding comes up or questions come up related to disability, especially in the hard times, not the good times are always easier, but in the recession years and the tough times, you really don't want them coming after this program to hurt a program like this. So that's just some of the vignettes. I'm gonna now go real fast through the history. I know you have these slides, so I'm not going to spend hardly any time, but it is fascinating to see how this program came about, basically. So actually, in Orange County, in this county, it kind of really started in 1959. Fairview, the 6th state hospital to serve people with developmental disabilities, was opened in Orange County. It was the last state institution to be built in California, right over in Costa Mesa. And the interesting thing, we just moved the last person out a year and 3 months ago, basically. They did use it during the pandemic for some hospitalization. But other than that, it is officially closed. It's not for DD anymore. But what's interesting in Orange County, families back then, and I know I talked to many of the moms that had their kids at Fairview, their pediatricians, when they were born and they had a developmental disability in 1959, 1960, 61, 62, the pediatrician said, you need to put your son or your daughter at Fairview. That's the place that's built for this. You don't want to keep them home. So a lot of those individuals, the only thing that they had was state institutions at that time. So it's very sad, but difficult for those families as when institutions were closing and having to move out. 1961, President John F. Kennedy, who himself had a sister with intellectual disability, appointed a president's panel on intellectual disability. And if you look back in history, you're not going to see intellectual disability. That's the appropriate word and the appropriate terms these days. But in the past, you would have seen the word mental retardation throughout this presentation. That's not a word to use anymore. We always want to replace that with intellectual disability. 1966, the birth of the regional center system occurs with 2 pilot centers opening their doors. In January of 1966, the Department of Public Health Bureau of Intellectual Disability negotiates contracts with 2 private agencies, and it happened to be Children's Hospital Los Angeles and San Francisco Aid for Intellectually Disabled Children. Those were the first 2 pilots. 1968, by June of this year, the 2 pilot regional centers are serving 770 people with developmental disabilities and their families. The number of people with intellectual disability living in state institutions in California peaked at that time at a record 13,400 people were in the institutions. In 1969, a proposal to reorganize California's fragmented system of services to intellectually disabled is reported to the State Assembly. Dennis Amundsen, an aide to the Assemblyman Lanterman, is the principal drafter. The report concludes that the pilot regional centers are successful and the model should be expanded statewide. I didn't mention, but when that pilot got started, how did that get going? Well, it was Assemblyman Lanterman who he was the powerful chair of the Ways and Means Committee, and there was 3 moms that kept on him about, you need to do something. My doctor told me I had to send my son or my daughter to an institution. We need to do something. You can't just have that, or you need to find, what can we do? Why would you want me to go to my son or daughter to go to an institution? So they knew that he had to walk from the Capitol over to the Senate Hotel. It's just not even 50 yards probably, but they did that walk with him almost every night for I don't know how long, weeks, and kept on until right up to the elevator, and till he finally really started getting it. And it was thanks to Assemblyman Lanterman that when he started looking at it, wow, the institution today could have been about $500,000 to $600,000 per person easily. And every person that we moved out of there is about 300,000. So that's considerably less than institutions. 1969, also buoyed by a proposal to reorganize, Assemblyman Lanterman introduced Assembly Bill 225 that extends the regional center network of services throughout California and establishes area boards for planning and monitoring services. Within a decade, the system includes 21 regional centers. Assembly Bill 225, the landmark Lanterman Intellectual Disabilities Services Act of 1969 is then signed by then Governor Reagan on September 4th, 1969. In 1973, Assembly Bill 846, authored by Assemblyman Lanterman, extends the regional center mandate to other developmental disabilities. It used to be all focused on intellectual disability, and now it included cerebral palsy, epilepsy, autism, and other conditions closely related to intellectual disability. The name of the Lanterman Act is then amended to no longer just intellectual, but Developmental Disabilities Services Act. A key, especially when we look at the disabilities today, there's some very, very mild CP, cerebral palsy. There's some very, very mild epilepsy. There's some very, very mild autism. So in those cases, it also requires that you have substantial disability with your developmental disability. So you'd have to have 3 areas of life skill challenges. Of course, if you're a child, the last 2 don't count. So it would be these 5 with children, and then these 7 with adults. So you'd have to have great challenges in your life in at least 3 domains to be considered eligible for a developmental disability in California. In 1975, Congress passes the widely heralded Education for All Handicapped Children Act, PL 94-142. The law mandates a free and appropriate public education in the least restrictive environment for all children, regardless of the severity of their child's disability. It also mandates the individual educational program, IEP, with special education and related services designed to meet the unique needs of each child. The 1975-76 budget for 20 regional centers, the 21st came in 1977, it was $47 million for 33,000, almost 34,000 individuals. And the average cost was about $1,418 per person. In this last fiscal year, 2021, regional centers budget is almost $9.4 billion, serving over 361,000 individuals at an average cost of $25,908. So that's it's quite the different program than it was then. And that's really because of the spectacular advances in the Lanterman Act, what we call supported living, individual living in apartments and specialized homes. The 1976, the Lanterman Developmental Disability Services Act is amended after extensive legislative hearings. It changes the eligibility categories for regional centers, serving services to include handicapping conditions found to be closely related to intellectual disability, or to require treatment similar to that required for intellectual disabled individuals, but shall not include handicapping conditions that are solely physical in nature. What that means is, in California, somebody can be riding a skateboard, sadly, and have an accident and get head injured, and they're going to be very similar to a person with intellectual disability. So that person would become eligible in this situation. Near drownings, surfboard accidents. Sadly, we get probably a dozen of those cases a year of accidents happening to what perfectly healthy kids that have accidents and come into our system. Now, the thing of solely physical in nature, that a muscular dystrophy is a condition that's purely physical in nature solely. Those individuals are not eligible for regional center. It's very similar to cerebral palsy, but it is not cerebral palsy, and it's muscular dystrophy. That's an example of a case, diagnosis that would not be eligible for under a developmental disability. 1977, the Lanterman Act is amended to give people with developmental disabilities the same legal rights and responsibilities guaranteed to all other individuals by the Constitution. So there's a landmark civil rights 1978, under Governor Jerry Brown, that's the first time he was governor, the Department of Developmental Services, DDS, is established as an independent agency rather than a division of the Department of Public Health. So it continues to grow, as you can see. 1978, Assemblyman Lanterman retires from the legislature after 28 years. Of course, you'll see that's prior to term limits. Legislators could go on a long time. He was a true champion of the developmental disabilities system. He was a big loss to our system. 1980, the state eliminates continuing care services branch and transfer to the regional centers the responsibility of people with developmental disabilities living in board and care and other community care facilities. So at that point, we took on the group homes that I've been mentioning as well. 1980, the California Penal Code is amended to require regional centers to provide assessment and recommendations to the court on some defendants with developmental disabilities in criminal actions. As I mentioned earlier, this is where the diversion clauses come in. How we can help the person stay safe so they don't have to be in a prison system if it was related to the disability. 1982, a Social Security Act amendment called the Katie Beckett permits states to use Medicaid funds for children with disabilities under the age of 18 who are living at home and would otherwise be eligible for SSI if they were residing in institutions. This was a great act because super medically involved kids would have been put away in institutions even up to 1982. This allowed for the nurse to be in the home up to 24 hours a day if necessary, but most of the time it was only necessary during wake hours, so they didn't need them during the night with the family. But to be able to have your child with you all the time was a big step, and that's what the Katie Beckett waiver allowed it. 1983, California is approved for participation in the federal Medicaid waiver program 3 years after its authorization by Congress. That program today is now accounting for about $4 billion, a little over $4 billion coming into California. And all the services I've been describing to you, that's what the Medicaid waiver program is able to bring in at this point, and it just continues to increase, of course. 1988, California is approved for participation in federal targeted case management, more federal dollars. And that's the federal dollars mostly associated to the social workers making phone calls, ID noting, and face-to-face visits and collateral meetings with psychologists, nurses, school staff. 1990, the American Disabilities Act establishes basic civil rights for people with disabilities, barring discrimination in employment and requiring accessibility in transportation, public accommodations, and all government facilities, services, and communications. So just barely 30 years ago, it's a huge change in our system. In 1990, by a 52% majority, Californians passed Proposition 140, an initiative addressing term limits for members of California Senate and Assembly. The proposition limits members of the Assembly to 3 two-year terms and senators to 2 four-year terms. The loss of many long-serving legislators like Lanterman had retired. Otherwise, there was others that had to be forced out because of the term limits. Interesting thing on unanticipated result is increased power to shape legislation among legislative staff members and lobbyists so a lot of times the district directors and the staff of the senator or the assembly member, they might be there 30 years working and they work for whatever senator or assembly member comes in, but the assembly person has to leave. So if you had somebody that was a champion of developmental disabilities or a champion of different things, they're forced out by term limits when they could have been voted out at any time. So it's a very interesting time. I know a lot of people thought, oh, that person's been in there way too long. They could have been voted out. So in some ways, it does hurt our system when there's senators or assembly members that really were strong and understood a cause. They will be forced out, and you have to start over again trying to educate the next senator or assembly member. 1992, McCorkadale makes significant changes to the Lanterman Act, and actually he was kind of the beginning of the person-centered movement. 1993, after 5 years planning, California implements the federal Part H early intervention program. I used that one scenario of birth to 3 years old. Basically, this means any child that has a delay of around 30% can receive the occupational therapy, physical therapy, speech therapy, in order to get back to what we call within normal limits. So this program that started in 1993, I know with us, all the children that come in that have some slight delays, 30% delay in speech or their fine motor or their walking, they will get to within normal limits by age 3 and be able to go on to normal school and everything. We see that at 85%. So early intervention is an incredible investment to make sure that children get that jump start and get back equal to the other kids in the neighborhood, so to speak. So very, very valuable program that allows kids not to have a lifelong system of a disability that might have continued on, but the therapy is able to bring them through it. 1995, for the first time in the United States, people living in settings of 6 or fewer persons constitute the majority. So you can see by 1995, across the country, institutions are starting to go away, and we're starting to get towards smaller group home settings of 6 or fewer persons living in. That's the new model. No more institutions. In fact, the last one was 1959 with Fairview. We were decreasing all along here at bringing people out of institutions and into the community. 2004, the legislature enacts Family Cost Participation Program, requiring families of minors living at home to share the cost of certain services purchased by regional centers. These cost-sharing requirements applied to respite. Respite is, you would think of it with a little kid as babysitting. But since it's with adults and everything else, respite is giving the family a break. So maybe we send a respite worker into the family home to watch one of our people we serve for 4 hours or so the parents can go out to dinner and catch a movie. That's respite. So we try to get families to use as much of that up to around 24 hours a month to get a few breaks and also daycare and camp is very helpful. That law became effective in January 1, 2005. What's starting to happen is you're starting to see our budgets were getting bigger, and recessions at different times were happening. And so they're starting to, let's do some cost participation from families. So you're going to start seeing a real theme here as we go. 2009, that was the worst recession we'd had since the Great Depression. Massive, the state was broke basically. So the legislature enacted changes at July 28, 2009, requiring the use of insurance was strengthened. We really, families were required to give me a copy of your insurance card, making sure that if we were purchasing a service, it could not be provided by your health insurance or other plans. Early start eligibility became more stringent, so they actually tightened that up. Respite was reduced. Utilization, how much you could use, was reduced as well. This is the beginning of, and you're going to see other things during this recession. Behavioral services changes. Parents must attend group trainings, no longer as much individual training. Parent had to be involved so that we could reduce hours and not have as much. Applied behavior analysis cannot be used as respite. When individuals served goals are met, regional centers will stop buying applied behavior analysis. And regional centers must evaluate every 6 months. So it just kept getting tightened. 2009 continued some of the cuts. Increased Medicaid waiver. We were able to bring in an extra nearly $1 billion in doing more work at a paperwork level from the regional center to get more money from the federal government, nearly $1 billion. And if we didn't do that, our program probably would not have made it through. We were able to get that extra $1 billion to not have some of the entitlement lost, basically. And these are all additional things that were put in place for savings. 2010, the legislature enacted even more cuts to the vendors and the regional centers, 3%, 4.25%. More transparency, more federal requirements. 2011, annual family program fee enacted, so more taking of money from the families basically where they could. If they were in a group home, they had to start paying a pretty significant portion. Financial management services. A number of things were put into place to spare the program basically because we are a private nonprofit. More recoveries, but now we're coming out of it by the year 2014, so they were able to restore the 4.25% cut. So they did a lot of restoration, but there was nothing ever above. So they you'll see as we go. A rate study was done back just in 2017 and found that our system is underfunded by about $1.8 billion. What that amounts to is because of the federal monies we draw is almost 50% of every dollar we spend on a person here in Orange County with a developmental disability, 50% will come from the federal government, get reimbursed. So that is estimated about 1.1 billion would be from California General Fund. So that's to take care of the vendor community out there that's underfunded. A little bit here more of just to give a synopsis. When the recession hit back, we were about $3.9 billion system. You can see we were able to hold our own during the recession, staying right around 3.9 billion. And then they restored the cuts in 2014, and we went up to about 4.3 billion. And then as of this year, almost 9.4 billion, but just about a $5 billion increase in services. What does that mean? It means the legislature pays a lot of attention to the regional center system and people with developmental disabilities today, because we're going to break the $10 billion mark this year. And the other thing I wanted to bring through is all of this services that I'm talking about, it's all coordinated by service coordination, case management. Currently, we're underfunded in that area by about 855 positions. That's why I mentioned caseloads were 85 to 90. They should be around 70. Regional centers operate at or under 15%. We're about 12% is administration cost. Everything else goes towards the people we serve. And so you'll see the value of the regional center system basically. And so one last area here, Lisa, what does the regional center system mean to a parent who has somebody with a developmental disability?
My parent perspective on this is that families do need to advocate. They need to advocate with their legislatures, locally and statewide, sometimes as far as federal. I advocate at the federal level as well to ensure that the services and supports through financial support continue with the regional center system. As you can see, California's population is, well, the whole United States population is increasing. And there's a certain number of developmental disabilities that are now coming into fold, either by better diagnosis or something else. We do not know exactly. For example, if that is true for those with autism, we do not know that. But we know that there is an increase in incidence today. So as a parent, I spend a lot of time working with members of the regional center, Larry, and the other regional centers statewide, lobbying for ongoing services and support. Not an easy job to have your legislators listen to you. But what that also means is that we have to basically share our stories, go out there, understand the law, understand the process, and just basically, hopefully we can continue this type of role of advocacy, because, you know, it's not advocacy in the sense where we try and just continue the ongoing support that we can get from the state to help us care for our loved ones. The state of California currently supports over 300,000 people statewide with a developmental disability. Orange County alone has roughly about 22,000. That's a lot of people. Even more important is that there are areas, health disparities is a big issue statewide, nationwide, and we want to make sure that we are also able to reach some of the populations that are underserved and not getting the services and supports that they need. So that's just my perspective, you know, taking away from my own home situation of having to care, but this is what I do for the regional center today.
Thank you, Lisa. And I skipped over COVID-19. In the past year, as a private nonprofit serving all the regional centers across the state, we were there 24 hours a day, 7 days a week, just like we have been for the past almost 54 years. Our population, we were able to get specialized nurses in situations where somebody got COVID positive, all those types of things. We were nimble, we were agile, we were right there on the spot, whereas some of the county services and things like that were months till they started getting operating. Some of the schools took over 6 months and still are struggling to get on pace. But the regional center system was able to react and help families throughout this in a very meaningful way. And I know that's bringing us to the end. I'm hoping that you've heard the vast array of services, just about anything that is related to a disability, we can fund, we can take care of and work with or find a generic resource. The successes are very clear, I think. California individuals with DD and families have been fortunate for over 50 years to have the Lanterman Act and this powerful legislation for developmentally disabled. Then the role we with those we serve, being birth to death, the relationship, all stages of life, very vital. And I guess the current goal is just doing everything we can to sustain this system that's there for the people we serve. And national surveys that are done that are independent from us show some incredible satisfaction in many areas. And that's kind of the Lanterman Act and the history of the regional center system in California. If there's a little bit of time for some questions.
That's outstanding, Larry. As people are thinking about questions, I do want to really emphasize first, just for those of you that are interested in leadership and advocacy, I just think the lesson of those moms that followed Assembly Lanterman, in between meetings and sessions was really powerful. And I just think it's so much about advocacy is just being present and being seen. And you also heard from both Larry and Lisa that being visible to elected officials is really important, that people understand and can draw sort of a personal connection to your mission. So I think there's a lot of lessons here that translate to broader interests in advocacy. And the second thing is you'll see that there is a little bit of a hesitancy sometimes in pediatrics to confer a diagnosis of a developmental disorder. But I think that, the things that we do to encourage parents to seek developmental screening and diagnosis, and even just to learn and just be able to understand what resources are available for early intervention are really, really powerful opportunities to just change the course of somebody's life. So just, I think there's a lot of place for that. But did any questions come to mind from the students as you were listening?
So I know for me, one of my questions regarding this topic is, can you speak a little bit in terms of Well, one of the things that I've always come across during the clinics is that I always get parents that tell me, I wish I knew more about the regional center, or knew about services for their child. And I was wondering what sort of efforts are being done in terms of outreach to educate parents in terms of when they do see some of these potential developmental delays, where they should go to receive resources.
Yeah, actually, Lisa's on here. She's the chair of my legislative and community awareness. Continuously, we're trying to look at ways that we get out. We do a lot of developmental screenings out in the community. We publish, advertise those like mad, where if you can just bring any child and have them screened. And there's incredible therapists that are going to check hearing, check vision, check their physical and occupational skills, and know if they get the full assessment and get into the regional center system. But that is one of the great challenges. I know our docs. We have 2 doctors, and they meet regularly with all the any big meetings of all the pediatricians, all the doctors, to remind them when they see somebody with any delay to refer them to the regional center system. But Lisa, go ahead, Lisa.
Yeah, no, Reese, I think one of the things that's probably very important begins with the pediatrician or our future healthcare workers. If any of you here, like I said, are going to be future physicians, what you're dealing here is with a family who doesn't have any experience with DD, or a denial. Culturally, there are many cultures out there that cannot accept the fact that they might have a delayed child, right? I mean, so it really begins sometimes with this type of alertness that would be at the physician's hands to, number one, hopefully know already about the regional center, but to refer the parent out. Okay. And I think the main job in here that's probably going to be hardest is that point where the physician himself or herself will have to refer and break this news to the family. So it begins there. I don't have that story. My story is actually an intern in a preschool who saw that my child was having an issue and referred us out. It was an intern.
That's amazing, Lisa. Yeah, and I think, one thing I've heard from parents too is the things that help them the most is kind of just destigmatizing language. Lisa mentioned that some people have a reluctance, and I think if you really do see things that make you suspicious of a developmental disability, even if you can't reach a definitive diagnosis, is to really encourage, parents, just basically that, just the notion, like, just imagine your child did access speech therapy or, applied behavioral analysis or something like that. These are just like wonderful, energetic people that are just going to pour into your kid, and it's a lot like play. I mean, it's going to be a really satisfying experience for your child that could help them just feel more comfortable. So just sort of like framing the positive aspects rather than the drawing conclusions about what the long-term prognosis will be, I think has been reassuring to some families.
I think we need to change the law where that would make it easier for pediatricians to also be able to talk about this, other than just refer them all out to a neurologist. But I leave that up to you guys and the health policymakers there to discuss or to look into.
Well, that's powerful stuff. I mean, I think that's one of the most important things we're hoping in this entire speaker series is to really understand, like, what are some of these leverage points or pain points or opportunities for improvement and advocacy. And I just think everyone here listening today can understand that basically strengthening that connection to accessing the regional center and these diagnostic opportunities will be invaluable. And I think we've reached our time, and I think I'm just so grateful, Lisa, to you, and Larry, to you for sharing this history, this context, the anecdotes, and of course your personal experiences as well. And we can't thank you enough. This is a topic that we don't get enough of in our medical training, and it's so valuable to us that you were able to join us today. So let's please extend a round of applause to Larry Landauer and Lisa Krasner.